Good morning, everyone, and welcome to Healing Heritage, Stories of Faith, Selflessness, and Service of Filipino Nurses. My name is Dr. David Chow, and I serve as the director of the Center for Asian American Christianity here at Princeton Theological Seminary. It is a joy to gather with you both in person and online for what promises to be an inspiring and informative event. Today's conference builds on the CAAC's longstanding commitment to exploring the intersection of faith, culture, and well-being. Many of you joined us in January for our mental health conference, where we learned how cultural narratives and spiritual practices shape our experience of health and resilience. Today's event, Healing Heritage, continues that important work by focusing our lens on Filipino nurses, a community whose rich spiritual legacy and tireless service have carried countless patients, families, and healthcare systems through some of the most challenging moments in modern history. That is not an understatement. Over the next hour and a half, we will hear about the Healing Heritage Project, an ambitious collaboration featuring Filipino nurses, researchers, clergy, and faith leaders. Through interdisciplinary research, compelling interviews, and heartfelt testimonies, this project illuminates the profound intersections of faith, race, and healthcare. We will learn about the project's origin story, how a shared vision for honoring Filipino nurses' spiritual heritage led to a pioneering collaboration across multiple institutions and locations. We will explore preliminary findings from interviews conducted in Virginia, New York, Chicago, California, and the Philippines, revealing how faith and cultural identity inform frontline care. Finally, our panel discussion will open the floor for deeper questions and reflections, inviting all of us to consider new ways to support frontline workers and uplift marginalized voices in healthcare. Filipino nurses have long been at the forefront of compassionate care, both in the United States and worldwide. Many of us have personally witnessed or even benefited from their dedication in times of crisis, including the COVID-19 pandemic. With each story we hear today, we come face to face with a tapestry of spiritual convictions and values of care that guide Filipino nurses' unwavering commitment to healing and service. By highlighting these narratives, we hope to spark broader conversations about how faith communities, healthcare systems, and academic institutions can partner to create a more equitable and compassionate future for all who need care. This is a hybrid event, and we are grateful to connect with both in-person and virtual attendees. We are immensely thankful for our sponsors, whose generosity and vision make this gathering possible: the Institute for Religion, Culture, and Public Life at Columbia University, Harvard Divinity School, Princeton Theological Seminary, the Louisville Institute, and APARI, the Asian Pacific American Religions Research Initiative. Together, these organizations and institutions reflect a shared commitment to bridging faith, race, and public health for the benefit of all communities. As you listen to today's presentations, I invite you to keep an open heart and an inquisitive mind. Let us honor these stories as sacred narratives that reveal God's work in the world through acts of mercy and dedication. May these conversations inspire us to envision more compassionate and culturally attuned healthcare systems, ones that recognize and celebrate the spiritual heritage of all who serve. It is my privilege now to introduce our speakers, Dr. April Manalong and Dr. Christian Gloria. Dr. April is Associate Professor of Interdisciplinary Studies at Norfolk State University, a historically Black university in Virginia. Trained in both the social sciences and the humanities, Dr. Manalong's research explores the intersections of religion, race, migration, and public life. She is a past recipient of the prestigious Templeton Foundation Early Career Award and currently co-leads a nationally recognized project on Filipino American nurses and faith communities during COVID and rising anti-Asian hate. Her work is supported by institutions such as Harvard Div, Princeton Seminary, and the University of Virginia. I am delighted to introduce also Dr. Christian Gloria, a public health scholar whose work focuses on resilience, well-being, and health equity among marginalized and immigrant communities. With over 20 years of experience in public health research and leadership, Dr. Gloria has served communities across Texas, Hawaii, and the Philippines. He currently leads projects focused on the health of Filipino American communities in New York and across the US. And he serves as a visiting scientist for the Philippine Council for Health Research and Development. And we are also delighted to include in our discussion today research from Christian's team, Amarie Rubio, Ther Largo, and Carlo Rivera. Let us welcome all of our speakers and panelists today. And I invite April to come up.
Good morning, everyone. I wanted to share a personal perspective about how I came into this project. I had a fancy speech prepared, but I think it's best to just share personally. So I'd like to invite all of you to go back to the time during the pandemic when we were all isolated. We didn't know how it started. People were dying. We didn't have a cure. And we didn't know what was going to happen. And at the time, I was actually, turned out I was pregnant at the height of COVID and anti-Asian hate. And so I was comfortably holed up, like a lot of us were, in our homes, in our apartments, socially distancing ourselves, probably ordering supplies from Amazon and whatnot. And so during that time, we were all watching the news. Our hearts in trepidation, just thinking about it is traumatic. But I can't imagine how traumatic it was for our nurses and for our Filipino nurses. And so I never honestly thought about public health or faith or the intersection of the two until COVID forced me to. That wasn't on my mind. I didn't see much in the news about Filipino nurses who are dying at unprecedented rates. We saw in the news about frontline workers and celebrated them. But it was a dual crisis for our Filipino nurses. On the one hand, more of them were dying than any other nurse who served others during COVID. They sacrificed their lives, their safety, their well-being. And yet there was very little to no media coverage on them. There's also little to no research on them. I checked. I didn't know that. But as someone who is Filipina, a proud Filipina myself, and as someone who loves my community, the Filipino nurses reached out to me. They called me. Honestly, I was taking a break being pregnant. I was so hungry and scared. That's what happens when you're pregnant. And so I didn't expect any of this. They called me and they said, "We are dying. We are suffering. We are isolated socially. We are holding the hands of patients who are dying every day. And we are the ones who are praying for them because they can't see their families. We are the last person they see. The last person they see before they leave this world. And we are afraid that no one will see us or hear us. Will you share our stories so we can be seen and so we can be heard?" That phone call, the phone calls, they kept coming. And I thought to myself, well, I don't know. I mean, I don't have that background. It's not my area of research. as Dr. Chow said, my area is in immigration and ethnicity and identity. But you know what, though? I felt a calling to do this project. I didn't ask for this, to think about these things, but I felt a calling to. And now here we are with this amazing team, with these wonderful people who also felt a calling. And I just feel grateful to God that we could center the voices of Filipino nurses so they can be seen and so they can be heard. So I just want to thank everyone today who is here to advance that endeavor. The last piece I want to say is it's more of a rumination than a personal story, because I've been reflecting over the years about why this project matters. Why does it matter? Like, on a personal level, I just shared why it matters. And I just wanted to share a little bit more after a lot of rumination about on the broader intellectual aspect of why it matters. And so this is an interdisciplinary project, and I think it's really important to talk about the value of storytelling and sharing our community stories of underrepresented communities. It's the story about how immigrants perceive themselves fitting into the larger diaspora, the diasporic landscape, and how we see ourselves fitting into the larger landscape, how faith plays a role toward that end. It's about thinking about the irony of the hero narrative, how on one hand the news said that they were frontline workers, but yet there was no media coverage on their losses amidst unprecedented levels of anti-Asian hate. It's about more deeply thinking about public health and religion as a vital component of analysis. Haven't really discussed that or researched that in previous years across all disciplines. And the last piece of this, of why their story matters beyond the personal, is thinking about social justice and reconfirming our commitment and embracing the diversity of that social justice and how faith may play a role in advancing social justice. Thank you.
Thank you, David. Thank you, April, and everyone. I'm not sure how to follow April's introduction. That got me really not only emotional, but remembering those years from 2020 and even to this day. And I guess before I get started, I just wanted to say magandang umaga, magandang araw. Christian Gloria, originally from Valenzuela, Metro Manila, and I had lived there till I was about 11 years old. And my family immigrated to California, to Los Angeles originally, as a result of Mount Pinatubo erupting in 1991. We were so terrified that we left the country and actually overstayed our visa. But that's a story for another day. I have been in public health since, I can remember. I've been in the profession for about 20 years now. After immigrating to California, my family then moved to Austin, Texas, where I went to school for about 13 years to get my bachelor's, master's, and PhD in public health and health education. And one of the reasons why I wanted to get into public health was because I knew I wasn't strong enough to be a nurse, because I just didn't have the strength to take care of people who were sick and struggling and needy, and I wanted to focus on keeping people healthy. On one side of my family, everybody would die from cancer. On the other side of my family, everybody would die from heart disease. And growing up as a child, I knew immediately that I did not want that to continue. I didn't want that to be my legacy, and I wanted to die peacefully in my sleep of old age one day, which is what inspired me to go into prevention and to public health rather than the pressures of growing up as a Filipino to go into either nursing or medicine. Interestingly, I'd been in the US for now about 30 years. I just became a US citizen 2 years ago. but I hadn't done any work with the Filipino community in most of my time in the US because I was so focused on, in a way, assimilating with the American way. But I knew I had a big heartstring still attached to the Philippines, and I began going back to the Philippines in 2017, um, just because I wanted to go back home and reroute myself. And I ended up, luckily, being in collaboration with the Philippine Department of Science and Technology, and ended up becoming the first visiting scientist or balik scientist of the Philippine Council for Health Research and Development in mental health, because that started sparking up as the new wave of mental health crisis. So in 2017, my goal was, with the government and the universities there, was to survey and monitor the mental health status of communities in the Philippines, because we had, as of 2017, no data about mental health in Philippine communities. And so my plan with them was to begin going village to village, community to community, starting in Pampanga, specifically with Angeles University Foundation. And our goal was, after collecting the data and then realizing that people were suffering from chronic stress, from all kinds of psychological, physical illnesses as a result of those chronic stresses, our goal was to use that data to then develop public health programs, mental health programs, to support holistic wellness among Filipino communities, particularly in the Philippines and also around the world. And so right when we were beginning to develop programs as a result of our data collection and our surveillance, that's when COVID hit. So I still remember vividly March 2020, I was in Makati in Manila when my trip there had to be cut short. My university summoned me, and at the time I worked at Hawaii Pacific University as a department chair of public health there. They said, you better come home soon because they're about to close the airports. And I had to do some emergency calls with, I'm still getting chills thinking about it, calls with United Airlines to get me a seat because everybody was evacuating. And I was one of the last people to get through the airport before they closed the doors behind me. And try not to get emotional about it. And to this day, I always felt a sense of guilt and a privilege that I was able to get out, because I know a lot of my colleagues in public health and nursing and medicine and allied health professionals, they were stuck, whether they were in the Philippines or Filipino Americans. They were stuck in the Philippines for at least 6 months. I know this was supposed to be short, David. I'll be quick. And so during the pandemic, I had to, coming from Hawaii at the time, I was in Hawaii from 2013 till 2021. I worked closely with the Hawaii nurses and saw what they were battling, this large unknown force that were killing a lot of people. Many of the Filipino nurses I worked with had COVID, but felt obligated to work anyway because they had no nurses to care for the COVID patients. And for the Hawaii nurses, the Hawaii Filipino nurses, they were faring a lot better than the nurses in the Philippines, who were dealing with a larger battle, a warfare against COVID, and having absolutely no resources. They didn't even have transportation. The military were blocking the roads. They couldn't get to work. They couldn't get to the centers and the hospitals. They were sick, and when they were sick, they were waiting outside along with patients who didn't have enough room in the hospital. So they were dying in their cars. They were dying in line and basically being sent home to die at home because there were no space in the hospitals. My research primarily has been with studying populations who are chronically stressed, like military personnel, military families, populations who are under-resourced, low SES, marginalized, vulnerable. And interestingly, I never studied Filipino communities until about right before the pandemic. And saw a lot of my colleagues suffered and died through the pandemic. And so I think it was a happenstance when Carlo brought sort of all of us together, glued us to April, glued us to other team members from other institutions. I was quite passionate about understanding the Filipino community, the Filipino nursing community, when I was in Hawaii or traveling to all kinds of conferences around the world. And when I identified to colleagues about being Filipino, the one thing they always say to me is, without the Filipino nursing community all over the world, we wouldn't have the healthcare that we have now, because much of the healthcare throughout the planet, fortunately or unfortunately, rests on the shoulders of Filipino nurses who are quite selfless. Many of the Filipino nurses I know live incredibly humbly in the US to give every penny that they can earn to get back home to support their families. Um, and so when I was invited to study along with April, I knew already in the middle of the pandemic in my study of how to keep people healthy and protected during the pandemic in a force that's largely unknown. um, I became particularly interested in the Filipino community because that's also when I learned how the faith communities really stepped in before anybody else could. The churches, the congregations, all kinds of faith and religious organizations stepped up to respond to the needs of communities, to provide social support, emotional support, instrumental support. They were quick to pivot everything to virtual rather than being in person. And the faith communities truly became a model for how should we respond in public health emergencies when we don't know what's going on, right? And so that really sparked my interest in furthermore studying the role of faith among communities, especially in Filipinos. I grew up as a Roman Catholic per my parents, and I don't really fully understand what even that means. And so this is also sort of a self-exploration back into my roots of what that is, because even though I identify as a Filipino and a Roman Catholic, I don't practice. And so it's something that's been refreshing over the years of working with April, David, and the team. And not to ruin any surprises, I'm really excited to share the results from our students who did a lot of the work in terms of the interviewing our participants across the country and all the way in the Philippines, and looking forward to discussions. So I'm not going to try to share too much of the findings for now. I'd love to call on up A. Rubio and Thur Largo. They originally were from UP Diliman in the clinical psychology program. I met them as faculty at Columbia University now, and they became Master of Arts students in clinical psychology at the Teachers College at Columbia University. Filipino students have a way of finding me. And so through cold emails, we found each other, and I said, hey, I'm doing this work. I'm in public health. I know a little bit about mental health, and the research that we're doing are primarily around psychology. And so it was really the stars lining up when the world introduced me to these wonderful two students. Amory recently graduated with the Master of Arts in Clinical Psych, and Thur's about to graduate next month. And so I'll stop there, and I'd love to pass the microphone over to you too. Thank you.
Thank you for that introduction, Dr. Gloria, and hello, everyone. We're very happy to be here and excited to report some of the preliminary findings of our interviews with different nurses in New York and in the Philippines. So yeah, Thur and I lived in the Philippines during COVID. We had one of the longest lockdown periods in the world. It spanned years. And so I think I can speak for the both of us when I say that we were very interested to help in this research because it felt like an extended period of helplessness, like being in lockdown for so long. And we wanted to really understand the experiences of different Filipino nurses, both in the Philippines and New York. So we will be presenting very preliminary findings, mostly just from New York and the Philippines. There are other sites in this study, but that's the portion of the study that Sarah and I are in charge of. And do you have anything else to add before we start?
Yeah, just to give a brief background, I grew up in Davao in the Philippines all my life. So I know it's like coming from the south of the Philippines where there's not a lot of representation in research and I guess in conversations, I was really passionate in bringing a cultural perspective into understanding mental health and well-being. And a huge part of the culture, in Filipino culture, is our religion, our belief. And we were hoping to see if that could be like a protective factor in understanding how we can help these underserved communities in managing their mental health and promoting well-being. So this is our research, healing the healers, because as we know, Filipino nurses are healers, and we explored how religiosity is a cultural protective factor among Filipino nurses during the COVID-19 pandemic. As we all know, Filipinos are the backbone of many healthcare systems worldwide. Yet their stories of resilience amidst suffering, inequities, and discrimination remain largely unheard. For one, Filipino nurses in the US comprise only 4% of the nursing population in the US. Also, a third of all the immigrant nurses in the US are Filipinos. But there is a disparity in that 1 in 3 of the nurses working in the US who have died during the pandemic are Filipino. So think of that. All the nurses in the US who have died, 1/3 or 30% are Filipinos. So you think, in contrast of this 4% to this 30%, there's a huge disparity there. And so to elucidate this sort of what's going behind the scenes and giving them platform to share their stories of resilience amidst like a very difficult time, we designed this multi-site qualitative study across the Philippines, in New York City, in California, Virginia Beach, and Chicago, to really look into what role does God or religion play in coping with the COVID-19 pandemic among Filipino nurses. And so for our part, Amir and I work primarily in the Philippines and New York sites. So we've interviewed in the past 2 years 20 nurses in the Philippines and 15 nurses in New York state and city. It was difficult to gather nurses. As we all know, they're busy people and difficult to schedule that around, but we got to interview those. And so we primarily looked at their COVID-19 experiences during the pandemic and even after that, explored religion and their mental health or coping and their well-being. So we did 30-minute to 1-hour interviews via Zoom. And as for like the settings of where do these nurses work, they worked in the hospital, in COVID facilities, in isolation facilities, in communities, and even in schools. So it's a diverse range of participants.
So our participants' age ranges were from 25 years old to 72 years old. She was really still kicking at 72, very sprightly woman. So shout out to her. Most of them identified as Christian or predominantly Roman Catholic. We did have a few participants who weren't Catholic. There was one who identified as both Muslim and Jehovah's Witness. And so there were some, I guess, outliers there as well. Ethnicity, most of them identified as full 100% Filipino, although there were also some outliers. I remember there was one participant who was half Irish, so that was interesting. And their occupations in terms of like the type of nursing that they were in really ranged. We had nursing assistants, community nurses. We also had a director for the nursing informatics department. So their experience was also quite different from nurses who worked on the bedside during COVID. So we have a pretty good range of participants. And also for New York, not all of them are from New York City. We really tried to have a diverse pool. So we had people from upstate New York and other regions in New York. And so for our methods, for the preliminary findings that we'll be presenting today, we focused more on content analysis. So content analysis is basically a research tool to determine how often do certain words, themes, or concepts were present throughout all of the interviews. Eventually, we do want to take a more comprehensive or deeper dive into those findings through thematic analysis. So identifying different patterns that emerge throughout the data. And in terms of the content analysis, we did do inductive and deductive coding. So we drew from both existing literature and our familiarization from doing the interviews to be able to see kind of like the main concepts that we wanted to look into. So there are two like main buckets, if you will, of codes that we had. The first is stressors. So I think Thur can speak a little bit more about this.
Yeah, so as we all know, the amount of stress like nurses face during the pandemic, it's a lot. It's like it encompasses different parts of their life. So in order to like organize these like parts of stress, we looked into a framework. It's the nurses occupational stressor scale, to have this organization of different stressors. And so these are the following sub themes or codes within those. So work demands, work family conflict, support from coworkers or caregivers of patients, workplace violence and bullying, organizational issues, occupational hazards, leaves, a sense of powerlessness, and unmet physiological needs. And then we thought that there was a missing piece to it that didn't really bring up the stress of the pandemic having a psychological toll on them. So we also added that in as a way to think of that stressor.
And then I know that's like a very convoluted image right there, but this was our main framework, if you will, for how we plan to continue analyzing our results. So just to briefly explain what that is, what that's saying, it's basically saying from the left, if you see the religion and spirituality, those are the different dimensions of someone's experience of religion and spirituality. And this image is basically saying from those different dimensions and through all of the mediators and moderators in the middle of that framework, that's how people end up either experiencing positive mental health or more negative mental health symptoms. So for the findings that we're presenting, we are starting only just on the left side of this image. So religion and spirituality. If you see, there are 5 boxes going down. That's public religious practices, private religious practices, religious commitment, religious experiences, and religious coping. So those are the different dimensions of how each person experiences religion based on Western monotheistic religions. There's a whole other framework for Eastern religion. So that's we're not talking about that today. So this was taken from the Handbook of Religion and Health by Koenig and colleagues. And yeah, we're just going to dive right into it. We promise we won't go through this whole framework. It's really just preliminary findings. So yeah. So we do have, so if they're talked about stressors, like the codes for stressors, our codes are what I mentioned earlier our codes are on religion and spirituality are based on that framework. So public religious practices are activities that different individuals take part in, connected to the beliefs and rituals of a broader community. So for example, Roman Catholics, and they're performed in organized social settings. So think about going to mass or doing rosary circles, which a lot of our participants did as well. And the second bucket of the religion spirituality experience is private religious practices. So basically the same as public, but you do it in private. You do it. So that includes like prayer, meditation, or a lot of our participants also talked about just talking to God on a daily basis, asking him for guidance on different micro decisions that they have to make in the nursing occupation. And the third bucket is religious commitment. So that just basically refers to how important is religion and scripture in my life. So some of the participants would say, religion is central to my work. Religion is the primary guiding force to everything I do as a nurse, and even in the work and family conflicts that they experienced as well. And then religious coping refers to the religious beliefs and behaviors used to cope with and make sense of negative or positive experiences. So basically, like I feel a sense of powerlessness, for example, because there's not a lot that I can do outside of my specific occupation. But I know that God has a larger plan for all of us, and I'm just going to have faith in that. And that's what helped me keep going throughout the difficulties that I faced as a nurse. So that's an example of religious coping. And the last bucket is religious experience. So this is more of the subjective encounters with the divine or transcendent. So think about like feelings of awe and wonderment, or like a deep sense of gratitude for your relationship with God. And an interesting little like preview here, we didn't really find a lot of the religious experience, or rather, a lot of the New York participants didn't have religious experience statements. It was mostly found in our participants who are actually based in the Philippines. So we won't have examples from New York participants for the religious experience specifically. And so we're gonna go through some quotes for each type of code or category that we showed you. So Dirk, you wanna?
Yeah, just to reiterate why we showed these frameworks, just think of them like we have this huge amount of data, and it's hard to like organize these like thoughts that they bring up. And so these frameworks provide us like a structure to say, oh, this quote from this nurse matched into that code. But yeah, so we built it through these frameworks and through our own familiarization of the data as well. So these are the codes that came up. So in work demands, a lot of them said that the roles during the pandemic significantly changed. Some of them had to take higher positions because these people, nurses, would have to leave work some of them had to have an increased amount of work because there are fewer nurses, so they have to take the responsibilities of those who left. So, for example, one nurse in the Philippines said that they had to take responsibility because they were suddenly tasked to head their entire team, and that they said that they took the responsibility because they felt that it's part of their profession and their calling.
So our next, I guess, group of concepts is about quarantine and isolation. So, of course, even nurses, once they have symptoms or once they test positive for COVID, they also had to isolate or quarantine, and usually it was about 14 days, especially at the start of the pandemic. And they did express having a difficult time with that because one, like they felt a sense of guilt for not being able to show up to work because they did have to isolate themselves. So, and one of our participants who was based in New York City, he was saying that New York City was completely empty during that time. And he felt it kind of added to his sense of isolation where it's like, that's New York City, you know, like he also worked during 9/11. He was in New York City for the longest time. So he's survived the HIV epidemic, 9/11, and COVID. And he said that COVID is the only one that was able to keep people away because there was no taxis, no pedestrians at all, and so that also kind of fed into his sense of isolation from the world. And so yeah, those are the themes that came up in quarantine and isolation.
And then they also mentioned, a lot of them mentioned that there were shortages in staff. So it's not just like nurses who were in, there wasn't just a lack of nurses, but also like a lack of physicians. So in these like moments of crisis, these nurses had to make decisions for themselves because there was only one nurse, one doctor for these 4 facilities. So they had to take that responsibility. And also just thinking if they were to get sick, they felt that sense of guilt that they would lose one more member of the team. So they just didn't, they thought beyond themselves and thinking of like how their absence might affect their team members.
And the next group of codes is about the risk for COVID. So that same New York City nurse that I was telling you about, he was saying that he felt really grateful that he didn't get infected because there was a patient that like coughed straight in his face, and he thought that he had like the face shield on, but apparently he didn't. So they do talk a lot about kind of their fear of getting infection or getting infected by COVID. And it relates to another set of codes in a different slide where they talk about like the fear of transmitting COVID to like people in their household who might not have the physical strength to be able to withstand COVID. So there's that as well.
I'd just like to add to that. In my interviews with Philippine nurses, a lot of them actually said that they never had COVID during the pandemic. I was like, wow, you work in the center or the epicenter of where you might think you would get COVID, but they didn't get it. And they would attribute it to being may ligtas point ako kay God because I'm doing this amazing work. That means like God is taking care of me. So it's just interesting to point out that they didn't have COVID during the height of it.
Yeah, and I would say the same for the New York participants. Like a lot of them got COVID either never or only after the height of the pandemic. And this in the next slide was what I was talking about earlier, where they were also like living in great fear and anxiety of transmitting COVID or other diseases and infections to their family. And that kind of connects to certain changes in family dynamics. So for example, this New York nurse at the second quote under family dynamics, he was talking about how he kind of was starting to think of maybe quitting or leaving the profession, which is something that had never crossed his mind before. He had very young children at the time, and his wife was also a Filipino nurse. And so they were kind of having doubts about should we continue this profession? Because what if we bring this sickness to our kids and something bad happens to them? And so he was grappling with that sense of doubt. But at the same time, like that's their main livelihood. That's the only way that they can support their family. So there was that constant push and pull of, I need to take care of my family by providing for them, but I also don't want to, inadvertently bring sickness or a disease to the house. So he was talking a lot about the kind of balancing act that he had to go through like every single day, especially with his wife also being a nurse. Do you have anything to add?
And then a very common code, or that something that came up across all interviews, that they had this great sense of uncertainty, especially in the Philippines where the vaccine only arrived, I think, in 2022. So this long wait for a solution to this pandemic. So a lot of them expressed this powerlessness for the end to the pandemic, to their jobs, to their safety of their families. So yeah, it came across most interviews actually, that this sense of uncertainty.
And then these codes talk more about the stressors of having to see patients not getting better. So that's patient conditions, and also being concerned about the patient's overall quality of life. So it doesn't necessarily have to do with them having COVID, but them not being able to see their family, or them being super uncomfortable because of the setup, especially if they were intubated. Like a lot of the nurses that we interviewed said they felt guilty every time they had to intubate someone, because they knew that that was an extremely painful physical state to be in. And so I would say that just also highlights how almost every single nurse that we interviewed talked a little bit about how they felt towards their patients, and how that was one of the reasons why they just kept going through extremely difficult circumstances, because they knew that they were the only ones that could be there for them during that time. So the patient quality of life, the second quote was actually it's a small part of a much longer quote, where she was talking about how the son of one of her patients was calling every single day saying, "Can I visit the hospital? Can I visit the hospital?" And she was like, "No, you cannot visit the hospital right now, but your father will be fine." But then just a few minutes later, the father started coding, and it was very sad because only the wife of that patient was able to see him before he passed away. And so that ties into, I would say, like another group of quotes that we have later on about grief. But before that, Thera will also speak on kind of the social isolation that they felt during the pandemic.
Yeah, as we in Filipino culture, we're a very collective culture. Our identity is shared, and um, it's a big sense of community. That's part of our culture, and so it was so difficult for them to be isolated, not only from their family but their friends as well. So yeah, even in the Philippines, it was a long quarantine period. It was terrible for me as a someone who was living comfortably in home, but how much more for these nurses who had to like physically isolate from their families. So that was a very common theme that came up across the data.
Yeah, and I would say also social isolation um, it was a very big challenge, because they felt like they couldn't also talk to each other much, because they were all kind of scared of like infecting each other or getting infected. And also something else that drove social isolation was the stigma. Like when people found out that they were healthcare workers, like they kind of stayed away like the plague. So that also contributed to that sense of isolation. And then, yeah.
And then just to go briefly towards the rest of the stressors, they've had a lot of fatigue and physical exhaustion. Most of them said that the PPE, or the protective equipment, was very hot to wear, so many layers, and it felt like they couldn't breathe. And so after every shift, they would say that it's very exhausting to them. Um, and with that, it also added to their anxiety as well, because if you didn't abide by these protocols of wearing these protective equipment, uh, you're more at risk for COVID. So they had a lot of anxiety towards their health, and not just like in terms of getting COVID, but also in other diseases going around as well. And also they had work anxiety, that they never felt this much nervousness coming into work, but because of the pandemic, they were showing up to work with these feelings of anxiety. I guess just to continue it, a lot of them also were in states of depression. A lot of them had problems outside of work. Like I remember uh, a nurse who just gave birth like a month before the pandemic. So she had this postpartum depression on top of working as a nurse. And so just thinking that it's not just the work that they have that causes these states of well-being.
And then, like what I was saying earlier, there was a lot of grief, not just for the patients that they were serving, but a lot of them also had colleagues who died from COVID or complications related to COVID. And that was also really feeding into their sense of isolation, their sense of depression, because it felt like they were constantly grieving these people, but they didn't really have the time to process it because they just had to keep showing up to work. So there was a lot of unprocessed grief that came up during our interviews. And now we're just going to quickly go over like the religion and spirituality findings that we had. So public religious practices were primarily focused on going to mass, even if that's virtually, having prayers before the start of a nursing shift, or having like these religious groups every week where they pray the rosary or they just talk about scripture and things like that. And then
I just wanted to add here, it's like very interesting to me that even if they were isolated, they managed to bring these public practices to hospitals themselves. So if you look at this quote, because they felt that their patients were so depressed and so lonely, these nurses actually found a way to broadcast these rosary prayers, these novenas to the whole hospital facility through speakers. So they would connect their phones. And it was so interesting that these practices were made possible even during these dire circumstances. So it wasn't just like you're left alone to practice your religion. They found ways to bring it online, to bring it across these barriers.
And then private religious practices, again, like I was saying earlier, it mostly consisted of personal prayer, a lot of prayer before they do any little micro decision at work. And yeah, praying before they go into a shift, praying after they come from a shift, and praying that they don't bring disease or COVID into their houses. So those are mostly what private religious practices comprised of. And religious commitment, a lot of them said that their faith in God became stronger. That was kind of like their bedrock during COVID. And yeah, some people were also saying that I wasn't very religious prior to this, but during COVID, that was the only thing that I had left. And religious coping, that was also one of our main findings, is a lot of them turned to religion to make sense of the negative experiences that they were going through. And yeah, religious experience, not so much. It was mostly in Filipino nurses. And so just to wrap everything up, third.
Yeah, so just like two key themes that we found, it's that the difficulties and stressors they experienced during the COVID-19 pandemic extended way beyond occupational stress. It occupied their family stress. It helped. It proved to be difficult for them physically and economically, and so think of it as not just them being nurses, but being as people as well.
And our final theme is faith under pressure. So religiosity really emerged as an active central protective factor among Filipino nurses, whether they do practice Catholicism or another certain religious denomination. So yeah, those are our final findings.
Thank you so much, Amory and Thur. That was a tremendous presentation, chock full of important data and preliminary research findings. I'm going to invite Carlo to come up and share some preliminary findings that have been done in coordination with Dr. April Manong's research. Thank you, David. Hello, everyone on Zoom. Hello to folks in the room. I'll just briefly introduce myself and then go into some of our findings in podcast format, actually, that Dr. Manong has been able to source. And so my name is Hans Carlo Rivera. I am a mental health specialist at Virginia Tech. I work with the employee wellness team as part of Hokie Wellness. I'm also a Master's of Public Health candidate at the University of North Carolina at Chapel Hill, actually graduating next month as well. So lots of graduates in the room as well. So with that being said, I'll go more into some thoughts to wrap up. But as David just shared, thinking about the podcast quotes that April Manong was able to source in initial interviews in Virginia Beach, and thinking how that establishes the relationship between faith and coping in the context of the dual health crisis that April mentioned, anti-Asian violence, as well as the COVID-19 pandemic.
I couldn't help but be struck by these deeply moving and personal interviews. I wondered, with over 80% of Filipinos identifying as Catholic, what role did faith play in coping with anti-Asian hate and the pandemic?
I believe that I am here on a mission by God, that every track I take is because of him.
I think faith is central to everyone, at least for me, growing up in the Philippines, being raised as a Catholic, faith has always been part of our day-to-day practice.
I think my relationship with God has always been a steady one. And I think it's always been, I never forgot that God was always there for me. And I think that's just part because of my upbringing, because my parents, my mother especially, she'd always go, did you go to church or did you pray to God? She taught me how to, do the rosaries.
And I think with what was going on with COVID at the time, faith has been really the one that connected a lot of us, because you can see the number of nurses that join the rosary prayers every night.
I think prayers kind of kept the positivity going, as well as not just for me, but praying for those that, needed or wanted the prayers if they were sick, or because some people were far more affected by COVID than I was.
I do the Our Father, 3 Hail Marys. I have a set of prayers that I do, and it's like it's automatic because by the time that I arrive to the parking lot of my hospital, I'm done.
Oh my God, and I pray for them. And I pray that it will be controlled. I pray that it will not affect my families, affect me, it will not affect me, my coworkers. I do prayer for them. And then after that, when that new patient comes, new assignment comes, I have to face the real thing again. In reality, I have to be there for him in reality for this patient, the next patient that I have. It was painful.
And I believe that if anything good happened about getting COVID within the world, I think more and more people got closer to God, more in the faith. I started actually doing the daily biblical through the Ascension in Catholic, in St. Gregory, and more involved about reading the gospel. So like I tell them prior to me starting my day, do not disturb me because I have to do my prior ritual by reading my Bible before I start. And I notice if I don't do that, my days goes crazy.
Sometimes I do bargain.
Like,
Yeah.
what was the bargain? So it's
That-
like usually if it's a bargain, someone gives you something in exchange. You do
Yeah,
something.
yeah.
It sounds like okay.
In exchange for the safety of my family, my patients, to have the thing under control so our normal lives will be back again, and everything. I really prayed for my patients, for my kids, since my son is also a military, and I don't want to be taking care of him, and the next one to be taken care of in that hospital bed. And I don't want to experience those. I really don't want a patient to experience any of that. We should not be having all that pandemic thing. It should not happen. The bargain that I made, I'm not following it now. So
I think you are. I mean, I think you were busy saving the world. I think God understands more than most people.
yeah,
You're saving the world. You saved so many lives.
yeah.
Do you think your bargain worked?
I think so, Lord. I think so. We have the vaccination. I had my third vaccination, all that already. So I think we're getting it under control.
Before wrapping up, I asked what they would want the world to know.
I think the public has sort of like stereotyped the Filipino American community as a silent minority. And I think they have to recognize that from a cultural perspective, we have suffered a lot of social political trauma, right? Coming from a country that has been under dictatorship for many, many years. So people need to understand the history before they can actually judge the why.
Filipinos are mostly in the medical field, and they're not well recognized. That's how I see it. And I don't know why. I don't know why.
Everyone needs to know that we all exist as a community and we're united no matter what color you are, no matter what your background is, no matter what your profession is, that we all have the same needs and that our health is very important and that it doesn't matter what race you are, that we're all here together and that as a Filipino community, together we can make differences in people's lives.
I hope that all the people out there understand that 4% of the nurses in the United States are Filipino Americans. And out of the 4% of those Filipino nurses, 31% died of COVID because we were front lines during the COVID pandemic and still are in the front lines. So that is a sad statistic because it just shows that we as Filipino Americans are the ones out there ready to give it all, including our lives and whatever it takes to make sure that we are compassionate and caring.
From our end, I think we can do more in trying to articulate who we are as a Filipino American community and what we can do to promote empowerment within our own community. And that's what PNAA has been all about since its inception in 1979. That it's okay to speak up and it's okay to acknowledge that even though we are a silent minority, we have done great strides in promoting ourselves and contributing to a large part to the healthcare industry here in America.
We are not seen as just workers, and we're not dispensable in a sense. We do our jobs. We do it to the best of our abilities. And I just would hope that people would take into account that we're here to help them. A lot of us as nurses, we do have caring hearts, and we also have families that we're taking care of as well. So I think grace and kindness go around for everybody.
Usually, wherever you go, wherever hospital you go, you see Filipinos. You'll hear from other people that say, oh, they're Filipino, they're a hard worker, they're caring, I want everybody to know that we are here helping, taking care of these sick people, and we are proud of being a Filipino nurse.
It is traumatic, but being a nurse, that's, I guess, part of our job to make things better, to make better decisions for the patient, to be their advocate, to be their stronghold, no matter what.
Those stories, right? The experiences of individual Filipino nurses who have contributed and sacrificed a lot in their roles, not only as nurses, but also as people who have immigrated to a country in order to seek out a better life for themselves and for their families. As was touched upon earlier in our session today, Filipinos are very collectivistic when it comes to our relationships with each other, right? There's this concept of utang na loob, right? The indebtedness of the heart, recognizing what we owe to each other. And for many of these Filipino nurses, these acts of service, this work, this labor that they do, it is more than just a paycheck for many of them. It is an act of service, it's an act of love, it's an act of community care. And so when we're recognizing the labor, right, a lot of times the conversation goes into how do we empower these communities? I would like to reframe that, right? Thinking of, instead of how do we give power to these nurses, we have to recognize that the nurses are the ones who are doing this labor, who are doing this work, who are doing this service. They are the ones who hold the power. So how do we allow these Filipino nurses here in the diaspora, the United States, or in the UK, in Canada, Australia, the United Arab Emirates, Thailand? I have family all over the world. Some of them are nurses, Singapore. How do we allow them to recognize and reclaim the power that they actually inherently hold with the work and the labor that they do? My background, as I mentioned, is at the intersection of public health and mental health. And in that conversation, what often comes up is a need to recognize the systemic influences that affect health outcomes. And so when we think about the experience of Filipino overseas workers, right?
a lot of the times it's because they are coming here to seek out better opportunities, better lives for their families, better paychecks. And so as I wrap up our session today, I kind of want to share my own reflections and tie it back to the origin story. And the first thing that I want to say, again, my name is Hans Carlo Rivera. Um, I am a second generation immigrant. My mother came here in 1993 to the Washington, D.C. area. I was born in Northern Virginia in 1995. But my grandma is actually from Ilocos Norte. And actually today is the anniversary of her birthday. She was born on April 11th, 1924. So she would have been 101 years today. And so this garment that I'm wearing is actually Pinilian fabric from her province, and recognizing that it truly is an auspicious date for me and being in community with you all virtually and in person. And so with the legacy of the Philippines, right, we've talked about how Filipino nurses have come over here. The Philippines was colonized by Spain for over 333 years, right? And it was sold then to the United States in 1898, following the Spanish-American War. It was bought in, as well as Cuba, right? And so with that annexation or occupation of the Americans in the Philippines, it really was a strategic outpost. And during World War II in the 1940s, as the United States entered the Pacific theater of World War II, the Philippines was used as a not only strategic base, but also a labor market. And so Filipino women were used and enrolled in nursing schools, and Filipino men were enlisted in the military in order to assist with the war efforts. And so my grandmother, being born in 1924, experienced a lot of the impacts directly during that time, along with Japanese occupation. And so that leads us to, current modern times. In the 1970s, with the Senior Marcos regime, the labor push was used to export labor in the Filipino diaspora globally, right? So I mentioned I have family in Canada, Australia, Paris, Switzerland, the UK, Thailand, Singapore, all over the world. I've been privileged enough to visit some of them in these places and stay there for free. So thank you. But recognizing, why is this such a global diasporic population, right, coming from the Philippines? And it really is because the economic forces in the 1970s drove people to leave the Philippines in search of an opportunity for better living, right? And so recognizing the systemic, political, social influences of power and where that's been placed, again, how do we allow Filipino nurses and overseas Filipino workers in general, OFWs, to reclaim and recognize their power? In the first year of my MPH program, my Master's of Public Health program, I was very fortunate to have two big supporters, Dr. Jennifer Platt and another professor, Leslie Derosette. And I presented findings on Filipino workers overseas, as well as Filipino nurses specifically. And they said, you could have a whole research project out of this, right? Kind of coincidentally, a few months later, I actually connected with Dr. April at a talk that she gave at Georgetown University. That was in January 2023. And I connected with Dr. Gloria a couple years prior to that, I believe, a year and a half before that. And I said, I think this is the universe showing me, some higher power showing me that this is meant to be, right? My mom is a nurse. My aunt is also a nurse. I have lots of nurses in the family. One of them is actually also a member of our research team on healing heritage, Melanie Obispo Young, who did a lot of the Chicago interviews for our Chicago site. She's, I don't know if she's joining us online, but she's a doctoral candidate at Loyola University Chicago, and also assistant or adjunct faculty in the nursing school at Lewis University nearby. My mom is a nurse. She worked in nursing homes. She's worked in emergency rooms, night shift nurses, right? So oftentimes these Filipino nurses are being placed in more vulnerable, less desirable positions within hospitals and healthcare systems. And that really sets the stage for this crisis that Filipino nurses face in the COVID-19 pandemic, right? In the context of all the things going on, these frontliners are in extremely vulnerable positions within the healthcare systems. And that is in large part why we have that disparity that Amory and Thayer mentioned earlier, that 4% of the nursing workforce in the United States are comprised of Filipinos, yet they make up 33% of the COVID-related deaths in the United States, right, in the first 6 months of the pandemic. And so when we think about these systems and structures that are placing these vulnerable communities at risk, right, how are we able to then protect them so that we can allow them to continue their work? I'm going to share a slide. We are still recruiting some more interview participants. So that's that QR code that you see on the screen. But I also wanted to mention really briefly, as again, I'm wrapping up, recognizing time coming, that I wanted to talk about our logo and what thought went behind that. So if you can see on the screen, Healing Heritage, it's a stethoscope, right? It's a stethoscope that's used in order for nurses to often hear heartbeats, breathing, and how, it's a symbol of healthcare, right? This shape, this almost infinity symbol, is reminiscent of the Baybayin character Ha. Ha is representative of breath in the Tagalog language and with Filipino people. That Ha is also reminiscent of healing heritage, right? Those H's, those H sounds. And so with COVID-19 being a respiratory pandemic, right, a respiratory illness, thinking about how that confluence of different factors shape what does breath mean? Breath is life, right? There's another Baybayin character, it's Ka, and it's two of these shapes, two of these wavy lines, kind of like waves, connected by a single line. So again, thinking about the relational aspect of Filipino relationships to each other, Ka means in relation to. So kababayan means my fellow compatriots. Kasama means who I'm with currently, who I'm together with. Kaibigan, kaibigan is friend, right? And so all of these things that relate to this inherent sense of being in community with one another, I want to argue and posit that a way that we move forward is to be in community, to listen to stories. With stethoscopes, you put it in your ears and you listen to their heartbeat, right? You listen to their breath. So I want us to leave here and really frame this as an opportunity to listen meaningfully to stories that are shared by the most vulnerable of us in order to really understand and empathize with the conditions that are going on, right? Again, thinking about the labor conditions and the policies that have contributed to exported labor in the Philippines to countries abroad. Currently in the Philippines, in Metro Manila specifically, the average daily pay, so what an average worker earns in one day, is around 645 pesos. That is the equivalent of about 11 US dollars, right? And that's in Metro Manila, which is one of the more affluent regions of the country. Thinking about more rural provinces or areas not in that area, it can be as low as half of that, so $5 a day, right? So there are really important conversations around the economic factors and structures that are consistently continuing to drive people to go abroad, but then also once they're here and contributing meaningfully to the labor market and to service and healthcare, and it's not just limited to healthcare, but cruise ship workers, domestic aides. My grandmother had Alzheimer's, and during the later stages of her life, she was taken care of by a Filipino overseas worker who was a stay-at-home health aide, trained as an engineer in the Philippines, left the Philippines to work abroad, and was essentially getting close to minimum wage, so around $8 an hour, to care for others, right? And again, this person was trained as an engineer. And so thinking about how we recognize the power that's held, it really requires a paradigm shift. And so part of that includes gathering research, gathering data, hearing stories, but then also coming together in spaces like this where we're able to share those findings and uplift the stories of Filipino nurses in the diaspora and in the homeland. And with that, I think that wraps up my time. Thank you all so much for coming. Thank you for folks who joined on Zoom. I will yield back to Dr. Chow.
So I am a theologian, and I'm interested in using empirical methods such as ethnography and oral history interview for the study of what I'm calling lived theology, especially the lived theology of Asians in North America, and in this context of Filipino Americans. Perhaps the big takeaway from this diagram that looks at intergenerational family life in the yellow circle, oh, thank you, there we go. This diagram here, as embedded within broader social structures such as migration and racialization in the US. And as a person of Christian faith and as a Christian theologian, I'm asking the question of how those intergenerational family dynamics and that social history of migration and racialization are related to something that we call God's economy, God's creating, preserving, saving, and reconciling work in the world. And the question or perhaps claim that I want to offer is that issues dealing with US immigration policy from 1965 onwards, especially issues dealing with mental health related conditions such as and we think of all the categories that Marie and Thayer had related. We think about the statistics emerging in the podcast that 4% of Filipino American nurses, 4% of nurses in America are Filipino, yet 30% of them account for the devastating deaths during COVID. A lot of that is inspired through issues of migration and racialization. Do these have theological significance? And in this framework that I'm using, I'm saying, yes, they do. So one of the big questions, and I'll kind of wrap it up here so we can go into Q&A. One of the big issues that I am grappling with as a Christian theologian is to dissolve the boundary between what is considered the secular and what is considered the sacred. And in this diagram, the reason I have in blue God's economy is to show how sacred values, those things we hold most dear, such as family, such as love of neighbor, such as care, these are theological. And as a theologian of Asian American life, we ought to pay attention to things such as our mental health conditions and our social structures and history as relevant to doing theology. So that would be the claim and desire for this integrated framework for studying Asian American Christianity.